Howard had a C-section before labor and a C-section performed before term. And I'll talk a bit later about including decidua and endometrium into your C-section suture. In fact, this is a typical case of a woman who had a C-section for severe preeclampsia before labor at 32 weeks. We see them all the time. In fact, you see a large defect, but what is more important is that scar is located about halfway in the uterus, very high on this, almost in the corpus of the uterus. So, and typically, when you do C-section with a uterus in labor and that stretch much, you do your best to see where we use typically a single closure and strangulate the tissue as much as we can in order to control the bleeding. And we end up usually with almost no remaining myometrium. And then, now that we know that about the height of the scar in women with prior C-section before term, we understand why those women are at higher risk for uterine rupture in the next pregnancy. And then the thing that there's a growing body of evidence that including the endometrium or decidua, whatever you want to call it, into your scar is probably the worst risk factor for uterine scar defect or uterine rupture in the next pregnancy. In fact, by doing that, you're putting your endometrial cells and line into the scar, and it's creating isthmocele when it heals. This is not just an hypothesis that has been proven in many ways. First, studies done in many animal models 50 years ago. Like Quebec. In fact, in France, everybody knows about that. So yeah, when you talk to most of them, they know that we need to avoid the decidua. And what Quebec showed is whatever animal they used, when it was including the decidua into the suture, there was much increased risk of adenomyosis and scar defect, while it was avoiding the endometrial, the decidual. Most of the time, he has no scar defect. And this is in agreement with human data. First, there have been 21 randomized trials that compare single versus double layer closure. And actually, in our last meta-analysis, we observed that when you look only at single versus double layer closure, there's no difference in terms of short-term maternal outcome, and also we cannot conclude about the risk of uterine rupture. On the other hand, all the studies that differentiate the type of single layer closure, those who were locked, and typically those who were locking their suture, were also taking the full uterus wall, including the endometrium. In those randomized trial in humans, we found again a thinner residual myometrial thickness in women who were closed with a single lock, including the endometrial closure. There's a trial that had been published 8 years ago who compared three types of suture. The single layer, including the endometrium, a double layer closure with the first layer taking the full thickness, and the second one imbricating, which is the most popular technique in Quebec right now. And finally, a third type of closure, which was to only reapproximate the endometrium together, or the decidua together, and then taking the second layer to reapproximate the myometrium. And what they found in that trial, if compared to the double layer closure, making sure that the decidua were approximated together, A single layer closure, including decidua, was associated with a 5-fold increase of uterine scar defect at 6 months. Finally, this year, a very nice Asian multi-center case control study on placenta accreta demonstrated that one of the worst risk factors for placenta accreta was a closure taking the inner side of the uterine wall, taking the endometrium. And this is in agreement with observational study who showed that a single layer closure with the locking technique, and most of the time including the decidua, was associated with an increased risk of uterine rupture, while a single layer closure, the French endometrium or decidua in the first layer, and locking that layer clearly increased the risk of uterine scar defect, increased the risk of placenta accreta, and most likely the risk of uterine rupture. So let's come back to the original topic, the symptoms of uterine scar defect. I wasn't able to talk about that without talking about uterus closure. I'm sorry about that. Anyway, look, it's the symptoms. Most studies that evaluate niche-related symptoms describe an association with postmenstrual spotting. Typically, a woman who will have a typical symptom for a uterine scar defect will be abnormal uterine bleeding. They will bleed 5 to 10 days after you have spotting, 5 to 10 days after menstruation. And the most likely hypothesis about regarding that symptom is it's blood and blood's accumulating in the scar defect, create clots, and slowly comes out after the menstruation. Moreover, it has been described that by the blood staying there, there's much more inflammation in that area of the uterus after menstruation. So you have 2 reasons why those women will have spotting. They will also have dysmenorrhea, chronic pelvic pain, and dyspareunia. However, it's most of the time related, associated with abnormal uterine bleeding in combination. There's also case reports of ectopic scar pregnancy and abscess that develop to the scar, but those are very rare, or less than 1 per 1,000 cases of scar defect. Interestingly, uterine scar defect does not complicate endometrial ablation with Novasure. There are 2 very nice large series that show that whether or not the woman had a uterine scar defect, it did not increase the risk of complications, so you can do them safely. However, it has been associated with an increased risk of perforation when putting an IUD. Therefore, if a woman comes to see you with abnormal uterine bleeding and you're considering an IUD, I would suggest whether you look at the scar before quickly on ultrasound and do an sonography. That's going to help you to see the scar and also to make sure that there's no other pathology into the uterus. Or at least you use ultrasound to make sure that when you're putting your IUD, you're putting it at the right place. And very interestingly, in the last 2 systematic reviews, scar defect have not been associated with recurrent miscarriages or infertility. Very interesting because surgical repair is becoming popular for infertility, but scar defect has not been associated with infertility in any studies, in fact. Well, let's talk about surgical repair. There's many ways. First, let's talk about the indication. I think the only indication right now is to decrease menstrual disorder, typically post-menstrual bleeding. There's no data on obstetrical outcomes. We're not sure whether or not it improves or increase the risk. And there's no comparative studies that look at fertility. So the different procedures are hysteroscopy, vaginal surgery, laparoscopic surgery. Most of the case series use hysteroscopy approach, and some of them use vaginal vaginal approach. In a woman who you use hysteroscopy, right, and you do a resectoscopic therapy, by just removing the scar around the defect and flattening the area so that there's no longer an outpouching where blood can stagnate, you improve the bleeding in most of the cases. In fact,
Emmanuel, we'll have 1 minute. 1 to 2 minutes.
In fact, the idea is just by flattening the defect, there's no blood that's staying there. Of course, it doesn't improve the defect, but it improves the symptoms. Interestingly, it works very well on an antiflaccid, but not on retroverted, maybe because it's more difficult to do. And the experts suggest that if you have less than 2 millimeters remaining mammogram, you probably should not do too much roller ball in order to avoid perforation and bladder wall irritation. Can we improve the original myometrial thickness? Yes, using vaginal surgery. You create a bladder flap, you push the bladder a little over, you feel the defect, and you can remove the defect and do a double layer closure. It works very well. It takes about 45 minutes procedure. It has been reported in many studies with many hundreds of women. It seems to be quite good. In fact, there's a comparative study that just been published last month. We demonstrated that when you do the vaginal approach, by far most of the women will greatly improve and won't have any more abnormal uterine bleeding. It's much better than hysteroscopic surgery. Besides that, it improves quite a lot the defect. So you can increase the myometrial thickness for doing that. I think so. Therefore, clearly, there's good comparative studies and good data showing that vaginal approach is very useful for the most severe cases. Laparoscopically, it's becoming more and more popular. I heard that in the U.S., in fact, in Witterson, it's becoming very popular. However, there's no comparative study. I don't know why we choose that approach, while the vaginal approach is quicker and easier and with excellent good data. There's a group in Belgium, a good surgeon, that showed that they could probably improve myometrial thickness in most cases, but again, their studies are very small, and there's no evidence that it improved the outcomes besides decreasing the bleeding. So there's a case was published this year. A woman came again before IVF. There was a very small remaining myometrial, so she underwent surgery. Came back 18 months later, same thing. She was now 40 to get her IVF. She was quite a bit disappointed about that surgery. So I think there should be more research in that field before we offer that to our patient. So in conclusion, uterine scar defects, a common finding after C-section is associated with abnormal uterine bleeding. Surgical repair can be performed through hysteroscopy, vaginal surgery, laparoscopy. Hysteroscopy is probably best avoided if myometrial thickness is less than 1.5 or 2 millimeters. Vaginal surgery is associated with the best outcomes so far. Laparoscopy data is interesting, but the benefits remain unclear. There's no comparative studies that have been done. And finally, I think prevention is the best therapy and will always remain the best therapy. After a next C-section, try to avoid decidua. I'm telling you, trying it, you will adapt it. So thank you very much.
Thank you, Emmanuel. Sorry for the pushing. We have time for one short question and short answer, please.
Thank you very much.